Hi, I hope everybody can hear me. Good afternoon. My name is Leslie Curson, and I have the pleasure of moderating the webinar entitled Immune-Based Therapies for Refractory Pediatric Leukemia for the American Society of Pediatric Hematology-Oncology. I have a few housekeeping items before we get started. Please note that all participants have been muted for the presentation this afternoon. I would like to direct your attention to the chat room on the screen. Please use this chat room to ask any questions, which I will direct to the speakers at the end of our presentation. You can also use this area to let me know about any AV issues or technical difficulties that you are having during the presentation. We have two fantastic speakers today who will provide a thoughtful framework in considering and using immune-based therapies in refractory and relapsed patients with hematologic malignancies. I'm delighted to introduce Leah Gore, who is a professor of pediatrics, medical oncology, and hematology at the University of Colorado Cancer Center. She is also Chief of Pediatric Hematology, Oncology, Bone Marrow Transplant with an endowed chair in Pediatric Cancer Therapeutics at Children's Hospital, Colorado Center for Cancer and Blood Disorders. Dr. Gore has extensive clinical research and practical experience with antibody-based therapies for relapsed and refractory leukemia. Today, she will review blinatumomab and related therapies given its recent FDA approval, and will discuss challenges encountered and helpful strategies when treating patients with this type of therapy. Our second speaker is Shannon Maud, who is an assistant professor of pediatrics at Perelman School of Medicine at the University of Pennsylvania and one of the physicians on the Hematologic Malignancy Service at the Children's Hospital of Philadelphia. She is the primary physician managing all of the patients receiving CAR-based immune therapies at the Children's Hospital of Philadelphia. She has treated more than 80 patients with this therapy at CHOP, which is the largest program of its kind. Dr. Maud will discuss the development of chimeric antigen receptors, CARs, as a strategy to target leukemia using gene transfer and review clinical trials utilizing CAR CD19 therapies for ALL. She will focus on scenarios in which one might consider this therapy for a patient and the approach to managing toxicities for patients undergoing this treatment. Without further ado, I will turn the presentation over to Dr. Gore.
Good afternoon. It's a pleasure to be here, and thank you for calling in. My disclosures are listed on the slide that you see before you. Let's get started. I think overall, both Shannon and I would like to talk about some possible uses and advantages of immunotherapeutic approaches for childhood ALL, and how these are really essentially pretty fundamentally different approaches than fundamental chemotherapy backbone regimens that we're all very accustomed to using over the last many years. And coincident with this is that many of these therapies have unique types of toxicities, and therefore different patient management strategies that I think we'll both discuss in sort of sequence. So just as a little bit of background for this session, as pediatric oncologists, we're very privileged that the vast majority of our patients are cured from many diseases that used to be uniformly fatal. However, some of the outcomes for some patients remain pretty miserable, and really over the last 20 to 30 years, we've made essentially no progress for the treatment of some very refractory diseases. Currently, I think one of our standard of approaches has been to escalate therapy to intensify both dose and frequency of dosing. And as a result, we're likely at our limits of therapy for dose escalation and intensity for many different treatment regimens. The converse of this also, that many of the new agents that are currently available for pediatric oncology indications, including a lot of approaches to ALL in the investigational side, are very young therapies, and they're either very underdeveloped or undeveloped in most children. So the fundamental questions become, when do we introduce newer agents to children, and in which patient populations specifically? One of the things that we think about as pediatric oncologists is what the long-term side effects of our therapy will be in patients 20, 30, and sometimes 50 or 60 years later. And the current drug development scheme actually makes that difficult to do, because the patients that we are treating are frequently multiply relapsed patients that may not have a very long life expectancy. But what has been a significant trend in medical oncology or adult oncology over the last perhaps 10 to 15 years has been that many cancers are being turned into a chronic illness with the use of frequent small molecule inhibitors that are often orally administered and can essentially turn a low level of present disease into a chronic illness, not unlike diabetes, where if therapy is taken every day, the symptoms and control of the disease can be quite sustained over a long period of time. We have not quite yet reached that for most pediatric diseases. However, there are some early examples in both solid tumors and liquid tumors that we've seen, and we'll probably hear more about both at ASH and ASCO coming up, as well as the ASPHO meeting this spring. So overall, acute lymphoblastic leukemia, as we know, is the most common cancer in the childhood population. And really cure and outcome for these patients is very risk factor dependent, which can be very clearly identified by the standard NCI risk criteria, as well as newer molecular and minimal residual disease technologies, as well as genomic and proteomic profiling. Because most children with ALL are cured with frontline therapy, we have enjoyed a lot of success. However, with relapsed disease, and particularly those patients with very early relapses of disease, the chance for a good outcome is significantly lower. We know that one of the predictors of poor prognosis is short duration of first remission, so that patients who relapse on therapy or very shortly after completing therapy have a particularly aggressive course typically and a similarly poor prognosis. We know that for many patients, a hematopoietic stem cell transplant can confer a significant survival benefit, but not all patients are really able to receive a stem cell transplant or can have an appropriate donor even if they do attain a second or greater remission. Transplant, while it can be extremely effective, is also not without its risks and toxicities, both short and long term. And as such, novel treatments that potentially advance the number of children who have relapsed or refractory ALL into a remission state are certainly would be certainly quite welcome in this therapy. So this list is just to remind us that most of the chemotherapy agents that we use for childhood ALL are quite old in nature. And the blue arrows on this slide really show, I think, a pretty profound gap between the approval of daunorubicin in 1979 and really essentially an almost 25-year time span before the next drug was approved for childhood ALL. So clofarabine did, I think, hit a landmark a bit in that it was approved for childhood ALL as opposed to adult. But secondarily, it was another 10 years before the next drug was approved for ALL, and the blinatumomab indication, which occurred just a little bit shy of a year ago now in December of 2014, did not specify children in the label, although it was interestingly vague about which patients may benefit from this disease and for which the label was indicated. Using immunotherapy for children with ALL, as we've talked about, is really a new strategy to try to increase the percent of children with refractory disease who may have a more positive outcome. We also know from basic immunology that memory T cells may kill autologous tumor cells if they're directed appropriately, and that the durability and control of the immune response is directly correlated with how disease-free a patient may be. And that isn't just limited to cancer, but it's also seen in infection, in autoimmune disease, and in solid organ transplant. And the line that everybody likes to put in their new grant proposals is that new approaches are needed, which is really quite true and not to be underestimated here. But the goals should be maybe twofold as we think about this. One is to improve the outcome for those patients who don't do well or who we know are not going to do well with early prognostic markings. But second of all, to really consider whether or not we may be able to reduce the overall burden of therapy for those children who are going to do fairly well, and think about the luxury of having long-term implications to be considered in upfront therapy delivery. So my task here is to talk about bispecific T-cell engaging antibodies, and specifically blinatumomab in this context. Blinatumomab is the primary example of bispecific or BiTEs. And it is, just for basic background on this slide, showing that CD19 we know is very highly expressed on ALL cells and B cells really throughout development. But it is essentially ubiquitous in B lineage cancers, and virtually all children with B precursor ALL express CD19 in very high percentages. Blinatumomab is a bispecific T-cell engager that redirects T cells in the patient's own autologous immune system to CD19 expressing B cells on the surface of leukemia cells. And in phase 1 and 2 studies, single-agent blinatumomab has had very substantial anti-leukemic activity in adults and children who have highly resistant refractory relapsed ALL, as well as in adults who have MRD residual positive disease to induce an MRD negative state in those patients. And in this diagram, I'm going to just try to get this here. So this is really the construct. Blinatumomab itself is really the name for this linker, which fuses a single-chain variable portion on the CD19 antibody to the single-chain variable portion on the heavy and light chains on the patient's own CD3 cells. And what this does is bring these two cells in close proximity to each other and actually induces site-directed lysis of the patient's T cells, sort of attacking the patient's blast cells. And by activating the T cell reactive cycle and continuing to do this by sort of a recirculation pattern of continuing to seek out the blast cells in the circulation and in the bone marrow, it actually induces both apoptosis and then a proliferation of the T cells that are stimulated by this process. So this is just another different way of looking at this, and the advantages to blinatumomab are several. One is that it really is able to act independent of the T cell receptor. So it's a direct link to CD3 here on the surface of the T cell, as opposed to requiring an intact T cell receptor. And then the second thing is that it allows us recognition of tumor-associated antigens on the surface of the blast. And in this case, it's CD19, but one can certainly imagine, and active research is going on with the development of other bispecific antibodies to other tumor-associated antigens. So it is really a very flexible technology that is not limited simply to CD19. The other advantage is that this is not dependent on MHC class I or on peptide antigens, so it allows a very specific cell killing and does not require specific matching at the major histocompatibility complex. So I thought we would start actually with a simple case study, because a lot of phone calls I get, and in fact one that I just had last night with one of our colleagues in Alberta, illustrates, I think, a lot of the things that I thought would be helpful to convey today. So I'm going to present a patient that actually came to our institution. This is a 3-year-old little boy who has a very undefined, or had a very undefined developmental disability, including language difficulties and some behavioral abnormalities, who was diagnosed with ALL. It appeared to be standard risk by all of our standard criteria, and he was entered on a COG trial, which is a standard risk protocol at that time. Unfortunately, he relapsed very shortly after completing his therapy, which, as we said earlier, was a poor prognostic factor that we're all quite concerned about. He had 2 reinduction attempts, one on an active COG protocol at that time, and then another using clofarabine, cyclophosphamide, and etoposide. And with neither of these reinduction attempts was he able to attain any sort of remission, and in fact had progression of his disease. So he, at the time of presentation, was about 6 years old, remained with some significant developmental abilities, although he was the size of actually even a large 6-year-old, and was really in medically fairly decent shape. And the question that his referring doctor had for me was, what are his options, and could we treat him on the active blinatumomab phase 1/2 trial at that time? So of course the answer was yes. And he was enrolled on COG AALL1121, which is the pediatric blinatumomab study conducted in North America in parallel with our colleagues in Europe. And the European side was conducted through sites at the IBFM. And so this was a very international study, and I think really a nice demonstration of how we can collaborate across oceans to conduct a number of these interesting, compelling trials. So this young boy started treatment at the recommended dose of 5 micrograms per meter squared per day. And about 16 to 18 hours into the infusion, he developed a fever and some flushing. His cheeks became very red and warm. And he wasn't so happy with us, but again, because he was nonverbal, it was very difficult for him to express himself. Within a couple of hours, he started to develop some mild hypotension and then more significant hypotension. And at that time, he also had evidence of a significant elevation of his AST, ALT, prothrombin, and PTT, as well as a drop in his fibrinogen. And so we watched him quite aggressively, and I'll talk about interventions in the next slide. But by hour 24, he was actually rather somnolent, not very interactive, but when we did try to check on his status, he was quite combative and really significantly different neurologically than he was even at his baseline, which is different from a child with pretty typical 6-year-old development. So this is disturbing for a couple of reasons, because we know that this child had been profoundly neutropenic for a long period of time. He had a central venous catheter, which would put him at risk for disseminated infection relatively quickly. And all of these symptoms actually could look a lot like sepsis, bacteremia, or something really bad going on. So the question is this an infectious process? Is this a impending sepsis and organ failure sort of situation, or are these symptoms related to blinatumomab? And sitting at the bedside, the question is, what do we do? Do we do nothing and ride it out? Do we stop the infusion? Do we start steroids because we think this may be an inflammatory mediated process induced by the blinatumomab? Do we do blood cultures or tap him because he's had nervous system changes? Do we start broad spectrum antibiotics? Because he's hypotensive, do we give him volume, and what sort of volume might we give him? And then looking at the increase in his transaminases and considering his neurologic changes, do we do any imaging pictures? Do we think about working this up in any more complete way? So what I'm going to show on the next slide is what we chose to do. This isn't necessarily the absolute correct thing to do, but what we did was not do nothing, because we're pediatric oncologists and we always like to do something. We did not stop the infusion, and I'll talk about that in a little bit. At that point, I did elect to start steroids on him and gave him, as I said, he was a pretty typically sized 6-year-old child, and in fact a little large for his age, and so I elected a dose of 4 milligrams IV every 4 hours. That's a little bit of a random dose, and certainly any typical systemic anti-inflammatory dose of steroid medication could have been used. I did elect to do systemic blood cultures in him, but not to do a lumbar puncture at that moment. But I did start broad-spectrum antibiotics, knowing that he had been profoundly neutropenic for a period of time, that all of his signs and symptoms could be associated with bacteremia, and wanting to make sure that we covered the possibilities that if he were infected, even if this was a drug side effect, that we at least had him covered until we knew what his blood cultures were going to look like. We also decided to give him volume at that time. And in the bullet point here, I recognize that vitamin K is not a source of volume expansion, but with his prolonged PT and PTT, we felt that that would be a relatively easy thing to support in him. But giving his volume as albumin and platelets, was the rationale for that was to try to keep a volume expansion in the intravascular space, because patients who receive blinatumomab and have this inflammatory type cytokine release reaction really have significant capillary leak. And I know Shannon will talk about this in her conversations as well. But to do everything we could to try to keep his intravascular volume intravascularly was very important. And so I always encourage people, if they're trying to give volume to a patient having these types of reactions, try to give it as something that's going to stay in the vascular space rather than leak out and actually cause more trouble with, for instance, capillary leak syndrome, peripheral pooling, which can get into significant problems with pulmonary edema, and in some cases has necessitated patients requiring intubation and ventilatory support. As far as imaging his liver and his brain, we at that point elected not to. If this had progressed or had caused other problems, that I think certainly would have been on the list of things to consider, both imaging the liver and particularly imaging the brain, and or doing a lumbar puncture and trying to obtain specimens with concern of a meningitic picture. So thinking about toxicity that can occur with blinatumomab, neurotoxicity is actually more common in adults than in children so far. But this drug has also been used more in adults than in children so far, and so I don't think we have a good sense about what the overall incidence will be, except for that it's quite common. And when neurotoxicity develops, steroid medications can be quite helpful. Overall, I think I have, along with many other investigators that have used this drug quite a bit, have evolved to thinking that we want to use as little steroid as possible for as short a time as possible. And that's because if we use too many steroids too early, that it really does seem to be associated with abrogation of the anti-leukemic response, which makes perfect sense. Steroids are lympholytic, and they will kill the T cells that you need to respond to blinatumomab. So if the patient has come into this therapy having been on very high doses of steroid, it's entirely possible that he or she will not even respond to the blinatumomab at all, which would be an incredibly significant waste of time and effort, not to mention the cost of the drug. The other thing that we found is that you can use a very short course of steroids, sometimes less than 24 hours or 24 to 48 hours, and that's all you need. And as a result, there really isn't a significant metabolic reason to taper those steroids, particularly if they're on a short course. So again, withdrawing steroids in a patient that is probably chronically immune suppressed is also a helpful thing to try to decrease the risk of infusion and infection and other long-term consequences. You may need to stop the infusion if the neurotoxicity is significant, and consider starting anti-seizure prophylaxis if the patients are not responding to steroids or other immune modifications well, and I'll talk about that in a little bit. But really the significant neurotoxicity that blinatumomab should be held for would be status epilepticus. For the most part, supportive care can be given through all neurotoxicity otherwise. And I'll talk about this in a little bit more detail in a couple of slides. But for most neurotoxicities, there is also a direct correlation with patients having an anti-leukemic response. So stopping the therapeutic measure that is getting them to that attempted anti-therapeutic response is also not a great idea. Once you feel that significant neurotoxicity has improved, the patients can restart at this low dose, but it is not recommended to escalate to the recommended escalation dose of 15 micrograms per meter squared per day if the neurotoxicity has been very significant. If the neurotoxicity lasts for more than 14 days, there is an official recommendation not to restart blinatumomab. Although in general experience, most patients are able to have resolution of their neurologic symptoms very quickly and are able to restart. That was true for the patients who received blinatumomab on the pediatric portion of the trial almost invariably. So additional management techniques. For cytokine release syndrome of grade 2 or higher, steroids are certainly okay once the toxicity develops, but as I mentioned earlier, I think most of us are trying to avoid giving too much steroid prior to the blinatumomab infusion, and certainly not for several days prior to the infusion as has previously been done. Shannon, I know, will talk a little bit more about tocilizumab, but for cytokine release syndrome that is not responsive to steroids or that is not responding quickly enough to steroids, you may consider administration of tocilizumab, which is the anti-IL-6 antibody that is now commercially available. Pediatric dosing has been established, so we have good data for that. Your pharmacist will not be pleased with you because it's quite an expensive drug with not super long half-life. But certainly it has been shown, as Shannon and Dave Tichy in Philadelphia and a number of people described in a Blood paper in January of 2014, it has been quite impressive in its improvement of toxicity induced by blinatumomab, as well as with CAR T cells that Shannon will talk about. DIC, TTP-like or hemolytic uremic syndrome-like picture has been seen more in adults than in children. But again, the care for this is supportive care. It is an inflammatory mediated process in these patients. And the good news is that it actually lasts a relatively short period of time. Supportive care is the most appropriate method for this. And it is absolutely appropriate to restart and dose escalate as scheduled if the patient's symptoms are improved and resolved. So this is just some data. Again, I'd like to focus your attention really primarily on the total of 70 pediatric patients that were treated at the 515 dose that's recommended. Of those 70 patients, 39% of them went into a complete remission within the first 2 cycles of treatment with blinatumomab. And of those, about half had full recovery of peripheral blood counts, and half had slightly incomplete or slower recovery of blood counts, although all of these patients eventually did seem to recover their blood counts, just not within the time period specified in that clinical trial. Very few patients had acellular marrow or low counts, and very few patients had a partial remission. Most of them either responded or didn't respond, and fortunately, and when this study was done, this is a very high % of patients responding compared to all of the other investigational agents that had been used for refractory ALL in the past. What I think has also really been impressive for most of the kind of leukemia world is that of these responders, essentially half of them were MRD negative. and it was a complete, deep, durable response. Half of them had less than an MRD negative response, and there were a couple of patients without significant MRD data that could be correlated. So again, this was really a landmark finding for children with refractory disease, for which most of us were up till this point accustomed to having very poor therapeutic outcomes. Next on this is just a little bit more detail about the younger patients who received blinatumomab. They were allowed to enroll on this study, and although their numbers were pretty small, only 10 of them were accrued. I think we all know who these very young children are. Most of them have MLL rearrangement or very refractory, sort of almost a bilineage or multilineage sort of phenotype. And of those 10, 6 of them went into a complete remission within the first 2 cycles. And again, similarly, they had a very nice MRD negative response rate. Again, very difficult to do that with conventional chemotherapeutic regimens for these patients. And of these patients who went into remission, 2 of them went on to stem cell transplant after achieving their CR. Again, adverse events are quite broad, and almost everybody on this patient had some sort of adverse event, but most commonly were things like cytopenias, which have a slightly different kinetic compared to most chemotherapy agents. There were some electrolyte abnormalities. I did note that there were some transaminase elevations that are noted in a few patients, and then fever, and essentially lineage depression from myelosuppression. Of these, almost all of them were patients that were very heavily pretreated, and again, patients that were thought to be associated to blinatumomab. So what was noticed in this pediatric trial is that the 2 toxicities of special interest really were cytokine release syndrome, noted in 8 or about 11% of patients. For some of them, they were quite severe. And neurologic events, again, for some patients, somewhat severe, but overall relatively well tolerated. Some of them were very subtle, like somnolence or some neuralgia. One patient was described as being confused. That would be the one I told you about. And very few patients actually needed to have treatment interruption due to these neurologic events. 2 patients did have grade 2 seizure. Both had their drug held temporarily, and both were able to restart therapy with blinatumomab. Both ended up achieving a CR after the first disease evaluation. And what's important about the neurologic events is it can be almost anything. It can be mild sort of hand tremors that really aren't terribly significant. It can be pain in almost any extremity. It may be bowel ileus. It could be small sort of fine motor coordination changes, or it may be very substantial with gait disturbance, almost somnolence, and very depressed state of consciousness, leading up to status epilepticus as noted in these couple of patients. What this correlates with directly, and I think it's very important for people to recognize this as I talked about strategies for management, is the peak effect of cytokine release in these patients occurs exactly at 24 hours. There were multiple cytokine levels drawn for these patients, and patients really top out at 24 hours, which is coincident with their symptoms, their clinical course. And then there's a very rapid fall off, as you can see in both of these, for the most significant cytokines, which were IL-10, gamma interferon, and IL-6. These are the most predictive of not only symptoms, but also patient response. And we also noticed that there were some cytokines that didn't seem to be very significant, and those are IL-2, IL-4, and tumor necrosis factor alpha did not seem to be substantially important in this cytokine flare. But that is, I think, relatively important for us to keep in mind as we think about when we're going to see the maximum incidence of side effects and really how quickly they'll likely drop off. And again, this leads us to the recommendation that it is likely possible to withdraw your steroid medications quite quickly because the inflammatory burst, if you will, gets over pretty quickly. So on the next slide, I want to talk just a little bit about what you shouldn't stop the infusion for. The first one is cytopenias, and I think it's been quite consistent that we see that anemia, thrombocytopenia, neutropenia, leukopenia, all are prominent with these patients, and as a result, they're all at risk for side effects associated with those cytopenias and should be provided supportive care as appropriate. But those cytopenias resolve usually within the first week to 10 days, and they typically recover quite quickly as long as there is an anti-leukemic response attained by the patient. So a patient who has aggressive sort of cytokine release or neurologic symptoms and has an ANC of 5 and profound anemia and thrombocytopenia at the end of that first week that patient is likely going to be one to respond. And in fact, that's quite similar, it's quite consistent with what we see with the responders who in the second week of therapy seem to all recover their counts quite nicely, even those patients that went into starting treatment in a significant cytopenic state. The other thing that you should not stop the infusion for is chemical lab abnormalities that have no clinical correlate. So very typically also by the end of the first week of therapy, we'll see transaminases elevated to 100, 500 times normal. And it can be a little disturbing when your patient starts with relatively normal transaminases and they develop a ALT or AST of 800 or 900. And I apologize for the Canadians on the line who use a different unit. Please forgive me for that. What we don't typically see with blinatumomab is a concomitant increase in bilirubin or other problems that would suggest veno-occlusive disease or typhlitis. This is not multisystem organ failure. This is a liver inflammation. We think probably attacking hematopoiesis perhaps going on in the liver or stored residual leukemic cells in the liver. So this is an important thing to recommend, that if you see this, it's probably a good thing and meaning that your patient is having a response. So overall, immune-based therapies like blinatumomab can be very powerful in their anti-leukemic activity in extremely difficult to treat patients who have refractory and relapsed ALL, including the ability to induce an MRD negative remission, which for some of these patients is the first time they may have been MRD negative. The adverse events that we see with blinatumomab we're understanding more and more about each day, and they can include very scary, very significant toxicities, typically cytokine release syndrome and neurologic toxicities. And in some cases, they can be life-threatening or fatal. However, the vast majority of these can be reversible and they're generally quite well managed with very careful intensive supportive care measures like we've talked about today. And the important thing to remember also is that they're very short-lived in their time course and usually are indicative of a good clinical response. So blinatumomab and a variety of other therapies, some which Shannon is going to talk about next, can be quite powerful. What we don't have significant data for now with blinatumomab at least is large numbers of patients who are many years out from their therapy without going on to receive a hematopoietic stem cell transplant or other more curative therapy. And I think there'll be a lot of time to tell what those potential moves are and what role blinatumomab has as simply a bridge to transplant versus a curative therapy. The longest pediatric patients now who have been treated with blinatumomab without subsequent stem cell transplant are about 3.5 years out, and those children are living in Germany. That's where one of the founding company for blinatumomab was first launched their trials, and Rupert Hengrittner was one of the first physicians to treat a child with ALL and blinatumomab. He shows a great picture of a long-term, relatively long-term survivor of refractory ALL who has not had subsequent therapy and is doing quite well to date. But those numbers are quite small, and so overall I have not recommended this be definitive therapy, but really to try to get children to a definitive therapy in much better physiologic condition than they might otherwise. So I'm going to conclude there. I will leave my thought about gratitude to the patients who participated, and this picture here shows the patient that I described to you in our case study, who is at the Great Sand Dunes National Park. Many of you may have seen this picture as I've shown it before. And what you see here under his shirt is his backpack pump where he is getting his blinatumomab infusion and surfing down the sand dunes. And he also went horseback riding while he received blinatumomab. So there is a quality of life issue that's quite positive for many of these children. I'm very grateful to my teams locally here as well as the Amgen team, and significant gratitude to the investigators and the clinical teams that helped got this drug launched and now approved for children and their families who took a chance on us and I think really allowed a new therapy to be developed for children and be much more accessible today. So my acknowledgments are listed here. Again, lots of thanks and gratitude, and I would like to potentially answer a question if we have time, otherwise turn this over to Shannon. Leslie, do you want to take questions now or do you want to go ahead?
Why don't we go ahead with Shannon, and then we'll have some time for questions at the end.
Perfect.
Thank you very much, Leslie and Leah. These are my disclosures. On this slide, I will be talking about CTL-019, which is licensed by Novartis. Leah gave you a great introduction to immunotherapy and to its role in ALL treatment. So I'll briefly go over how CAR therapy is similar and how it differs. Immunotherapies take advantage of the immune system's killing machinery, specifically cytotoxic T cells, which is what we're discussing today with both of these therapies. In order to do that, though, we have to overcome the tolerance that cancer cells have developed and direct T cells to tumor cells. BiTEs are one way of doing that, and a second way of doing that is through a chimeric antigen receptor, or a CAR. CARs link an extracellular antigen recognition domain, usually an scFv domain derived from a monoclonal antibody, to intercellular T-cell activation domains, with most current CARs containing the CD3 domain of the T-cell receptor plus a co-stimulatory domain. And that is either CD28, which is used by several groups, or 41BB, which is shown here and what is used by our group at Penn. The T cells are engineered to express the CAR, often through a viral vector technology, and that's what I'm showing you here. We use a lentiviral vector to transduce T cells, and these are T cells that are collected from the patient through a leukapheresis procedure. Then once expressed, the CAR can direct the T cell to the tumor cell, and the T cells are then expanded in the lab, and they are reinfused into the patient, where within the patient they come in contact with the antigen of interest. This binding to the antigen of interest engages the CAR, and that stimulates a cytotoxic T cell response as well as cytokine release and exponential proliferation. So this is quite similar to what Leah described with blinatumomab, but what we are infusing are T cells that are directly expressing this CAR protein. We have found that CAR-modified T cells directed against CD19, also called CTL019 cells or CART19 cells, that these can persist for months or even years and therefore have the potential to provide long-term disease control in the patient. But what does this look like in real life? So when infused, the T cells, which are typically anywhere from 10 to 40% CAR modified, once infused, they're redistributed throughout the bloodstream and the marrow. So on this slide here, what I'm showing on the top in the red box are flow plots which show the percentage of CD3 cells that are CAR modified. And on the day after infusion, there are no CAR19 cells detected in the blood. But if you look later on at 2 weeks, when there has been substantial, really specific proliferation, you can see that greater than 70% of the CD3 cells in the blood are CAR modified. And this proliferation can be on the order of 100,000-fold in the patient. This then contracts over time as the target is cleared, but as I'll show you later on, these cells are able to persist for long periods. So more importantly, what does this actually do for the patient? On the bottom here, I'm showing one example of a flow plot from an MRD specimen from a bone marrow report. And this shows that the bone marrow was packed with leukemia on the day prior to CTL019 infusion. And that is then cleared by day 28. And you can see that not only the minimal residual disease, the leukemia is cleared, but B cells are cleared at this time point 1 month post-infusion. This is held true as more patients have been treated. I show you an update of our phase 1 study at top. This is in patients with multiply relapsed or chemo-refractory CD19-positive ALL. 2/3 of these patients had relapsed post-bone marrow transplant, and we were seeing a 94% complete remission rate at 1 month after CTL019 infusion. So who are the potential candidates for this therapy? Right now, patients who are potentially eligible for this therapy are those with BALL in second or greater relapse, those who are refractory to standard chemotherapy, or any relapse after stem cell transplant. In these early phase trials, we have standard exclusion criteria, so that includes kidney, liver, cardiac, and pulmonary dysfunction, and active infection. But in addition, both for safety reasons and because this therapy requires a personalized manufacturer, meaning a time lag, patients with rapidly progressive disease that's not responsive to any therapy are not good candidates for this therapy. So logistically, we often are thinking about this time lag and what does that mean in terms of the best timing of leukapheresis, which is required for this therapy because we need to collect cells to be able to re-engineer them. So there's two sides to this and sort of a balance. Do we reserve pheresis for patients who are known to be eligible because they are relapsed refractory patients? Or do you consider pheresis in patients who are very high risk of relapse and may potentially, in that situation, actually get a better T-cell product because they haven't had as much exposure to intensive therapies? So that's the upside of doing that, but there's the downside that these patients may potentially undergo an unnecessary procedure. So we think about these things, and we've done both scenarios in patients referred to us. This process can take several weeks to a couple months, depending on the wait list. So in that time between enrollment, manufacture of cells to infusion, a patient has to be stabilized while the cells are being manufactured. So I wanted to talk a little bit about the process of stabilizing the patient because these patients can sometimes be several weeks in between the time they come to us for enrollment and when they actually get treated. And the goal during this time is to keep the patient stable and prevent rapid progression, but not necessarily to induce remission or even reduce the disease burden. And the reason for that is that intense therapy, of course, runs the risk of organ toxicity or infection that would delay or may even preclude them being infused down the road. So many patients are stabilized on low-intensity or maintenance chemo, which feels a bit strange to all of us, but has really worked for the majority of patients we've treated. The infusion itself, I often say it's pretty anticlimactic. It's done as an outpatient. The patients are pre-medicated with antihistamines and antipyretics as pre-meds, really a typical pre-med for a cell infusion or even a transfusion. And the patients are then monitored for some period as an outpatient after infusion, but acute infusion reactions are really quite rare. The primary toxicity comes later, and that primary toxicity is cytokine release syndrome, or CRS. It is a result of the T-cell cytotoxic response and cytokine release, as the name implies. The symptoms can range anywhere from, on the mild end, of flu-like symptoms with high fevers, myalgias, nausea, and vomiting, which can start as early as the first 24 hours after infusion or go up to 14 days later. It can range from that to the more severe CRS symptoms in a fraction of patients. And severe CRS with hypotension, respiratory and renal insufficiency, and coagulopathy progresses over several days after the fever starts. Clearly correlates with disease burden, and that really is because the more targets means more proliferation and more cytokine release. So I wanted to go through two cases as some representative cases of the range of CRS. The first case is a 9-year-old female who was referred for COVID-19 for a relapse after allogeneic stem cell transplant. She received a 4-drug reinduction and entered remission, and then came to us and had T-cells collected, and actually received no further therapy until returning to us for infusion. At that time, she received fludarabine and cytoxin for lymphodepletion, and at the time of infusion, did have detectable disease in the bone marrow, but it was low, with 5% blast in her bone marrow. She was then infused with CTL-019, and within 48 hours developed a fever, which is shown here with the green line.
she was admitted at the time of fever and continued to have several days of fever, myalgias and nausea and vomiting. But by day 7, the fevers were gone. She was discharged the next day. And this really is a typical CRS course, and what we see in the majority of patients who experience a mild course with a day to several days of fever and flu-like symptoms. And on the opposite end of the spectrum is case 2. This is a case of severe CRS. The 22-year-old male who was in first relapse, was highly refractory to chemotherapy. He came into infusion with a packed bone marrow, and he was then infused with CTL-019. And again, similar to the other case, developed a fever within 48 hours, but his course became much more complicated over time. And what you can see here is the course of the temperature in red, and I've indicated some of the support that he required in the lines below. So over the course of the first 5 days post-infusion, he developed vascular leak and severe hypotension, requiring multiple vasopressors. And as Leah indicated so well, this vascular leak can result ultimately in intubation, usually from pulmonary edema, although there may also be some direct inflammation in the lungs that leads to intubation in a fraction of these patients. He did receive the IL-6 receptor blocker tocilizumab, which we use in this scenario of severe CRS, and had a transient improvement, but not a complete resolution. And typically we see a complete resolution fairly quickly after tocilizumab. So he then received high-dose steroids and a second dose of toci with subsequent improvement. This case also highlights the significant coagulopathy that we can see with this therapy, and as we mentioned, that can be seen with blinatumomab as well. What we have noticed is that it's really marked by a profound hypofibrinogenemia requiring cryo. So this patient and most of our patients, similar to, as Leah mentioned, we often are giving blood products both to support this coagulopathy, but it's also a good way to volume resuscitate these patients to avoid developing excess fluid overload. So these cases illustrate the primary toxicity of CRS. It really is the main thing that we see. It correlates with T-cell proliferation, and it's probably needed to some degree for efficacy. CRS severity is definitely related to disease burden, and it can be reversed with cytokine blockade. The first pediatric patient treated with this therapy received tocilizumab with dramatic effect on severe CRS, and this has now been incorporated into our management and the management of several groups using CAR T-cell therapy. Another toxicity of note is encephalopathy, which has been reported with several CD19 immunotherapies, as you just heard about as well. And then, of course, B-cell aplasia is an on-target but off-tumor toxicity and requires immunoglobulin replacement for the length of time that there is B-cell aplasia. The management of severe CRS elements go over briefly. It's both symptomatic with vasopressor, respiratory, and blood product support. It's also targeted at the underlying process. So the initial management of this therapy was with steroids to really try to block some of the T-cell proliferation that was causing the cytokine release. And that was somewhat effective, but there is, of course, the concern of reducing efficacy if you are affecting T-cell function or killing T-cells. So IL-6 receptor blockade with tocilizumab was then found to be highly effective without an effect on T-cell proliferation, and is really our front line, although we do go to steroids as needed. This plot shows the correlation of CRS severity with disease burden. As you can see here, patients with greater than 50% blast in the bone marrow at the time of infusion are at high risk of severe CRS. While not absolute, it is much more common in that group. While patients with low disease burden are at much lower risk. And this graph is showing patients with severe CRS to the right and those with less severe CRS to the left. So I now want to shift to what happens in the after the initial post-infusion period, and what the follow-up has been on the study. As I mentioned, the initial complete remission rate is 94% at 1 month. We've now been able to follow many patients further out, as very few of these patients have proceeded to stem cell transplant. We do have patients who are in remission greater than a year, and 10 of those without further therapy. Median follow-up is still less than a year, but we are now getting patients who are out beyond 2 years and 3 years. We have seen relapses in a third of the patients, and the primary relapses we're seeing now are CD19 escape or CD19 negative relapses. So I wanted to show you what I mentioned earlier, that these T cells can persist for quite some time. Graph on the left shows on a per patient basis the persistence of the T cells in blue. And on the right really shows you the probability that patients will continue that T cell persistence up to 6 months or longer is on the 70% range. To show you our longer-term follow-up here, I'm showing you disease-free survival and overall survival for these first 48 patients treated. As you can see, the 6-month disease-free survival is 72%, and overall survival is about 80%. We're hoping to get more longer-term data as our median follow-up gets longer, and hopefully we can predict what that disease-free survival is going to be further out, even to a year and beyond. Long-term management. So these patients do require a long-term follow-up, even though they're not continuing to receive therapy. They do have chronic B-cell aplasia for as long as the T cells persist, and they require monthly IVIG, or in many patients who get this long-term, we switch to subcutaneous immunoglobulin with good results. They require close follow-up for persistence and relapse in the first year, but beyond that, because this is a gene therapy, there's FDA-mandated long-term follow-up of 15 years for these patients. In the end, I just wanted to mention that I talked specifically about the therapies at CHOP. CAR therapies, as we all know, have been developed in other institutions as well, and we're seeing similar initial response rates of these therapies. They show there are some differences with the design here in the co-stimulatory domain between our group at Penn and those at the NCI and from Kettering as well as Seattle. And what we're seeing is that the CR rates are really quite similar. However, the persistence of T cells may be something that distinguishes these CARs, and probably related to either the co-stimulatory domain probably has a big part of that, and potentially the manufacturing as well. So in the end, I just want to summarize the potential of this therapy and to think about what is the future. We know that we can induce deep remissions with immunotherapy, but this type of immunotherapy is blinatumomab. I think the question for some of the T-cell therapies going forward is, can this actually achieve long-term remission? And moving forward, this therapy is now being moved into larger multi-site trials and is available at several centers in the U.S. and Canada and Australia. And there is a trial in development to hopefully move this up front for certain very high-risk subsets. And I want to thank, just like Lee did, thank the patients and families who have been involved in this, and all of those who have really played a role of bringing this therapy to patients. Thank you.
Thank you so much to Drs. Gore and Maud for their informative and thought-provoking presentations. I'd like to remind the participants to use the chat room to raise questions or make comments. We have just a few minutes for questions for our presenters. So I'd like to start with Dr. Maud. The data you presented suggests that not all patients in remission went on to stem cell transplant after CAR-T therapy. In general, do you recommend this treatment as a bridge to transplant for patients who achieve an MRD negative remission?
It's an excellent question, and I think it's something that is evolving over time as we get longer-term follow-up on these patients. one of the primary reasons that most of our patients in remission have not gone on to stem cell transplant is that about 2/3 of patients came to us relapsed post-stem cell transplant. So they would be going on to a second or third, or in some cases even a fourth bone marrow transplant. And because of that, we've been able to get longer-term follow-up without transplant, and now have some data that at least a fraction of patients have a potential to stay in remission for long periods, greater than a year, in our group of patients. So what we do now is patients who have not had a stem cell transplant, we talk to them about it and say that it is standard of care, but provide them and their referring doctors the data that we have to sort of indicate what are the chances that this could potentially be persistent in some patients.
Great, thank you. For Dr. Gore, you described that one of the indications for stopping the blinatumomab infusion was neurotoxicity, and in particular status epilepticus. Are there other situations in which you would discontinue the infusion? It sounds like it's difficult because it could be the sicker patients could be deriving benefit, but it seems like it's a difficult call. So I'd be curious to hear your thoughts on that.
Yeah, and I think no matter how many of these patients you see, and they are going to all have a range of side effects and symptoms, but most of the time, status epilepticus is really the only significant reason that you would need to stop. There have not been reports of anaphylaxis to blinatumomab, although there was one patient that reported some anaphylactoid-like symptoms, which is very unusual. And really to date, that's been the significant, the status epilepticus has been the one that I think most people are feeling very consistent about. There are patients who have had their drug held for some period of time, and again, it has to be up to the level of comfort of the treating physician who's there on site. Our policy here is that we pretty much have the kid in the ICU for the first, at least 24 to 48 hours, because if they get sick, they can get sick quite quickly. But we have been able to treat through all of the side effects and symptoms that we've seen to date, just with a lot of supportive, sometimes ICU level care. But we have not had to stop the infusion for anything else. But ultimately, it's up to the person who's at the bedside, recognizing that if you stop, it has an extremely short half-life of about an hour and maybe 25 minutes, an hour and 15 minutes. So it's very, very quick on, very, very quick off. But the constant engaging and re-engaging of those T cells might actually extinguish the response, much like has been described with CAR T cells. And so the risk of turning off and on actually risks sort of an immune exhaustion type phenotype, which Crystal Makel and a number of other investigators are starting to report more frequently. So my particular bias is that you don't turn the infusion off for very much less than status epilepticus.
Okay, very helpful. Dr. Maud, what's the chance of getting an adequate T-cell harvest in patients receiving relapsed chemotherapy given their lymphopenia, and it seems unlikely that they could be off treatment for weeks to months in order to ameliorate this?
Right. So we typically plan collection at a time when a patient is recovering from a cycle of chemotherapy and have guidelines for what we like to see in ALC and CD3 counts. But we have really been able to have pretty good luck in patients who are receiving relapsed chemotherapy, and certainly after a standard 4-drug reinduction, we've been able to get a collection, or after a regimen like VP cyclo. The one drug that has caused significant problems for getting an adequate collection is clofarabine, and often that takes quite some time to recover from.
Okay, we will do one last question. This could be for either one of you. Do either of you know of a working group for immunotherapy and refractory cancer in children similar to Bone Marrow Transplant Consortium has?
Shannon, do you want to go ahead with that?
Sure. So, some of the transplant consortium have sort of delved into this and combined cell therapy into that as well. There are some cell therapy groups that are particularly research focused. But I know that the transplant groups like CBMTC have some interest in cell therapy as well. There's not a specific working group in terms of clinical trials.
Okay, thank you. Unfortunately, our time is just about up, and I recognize that there are several participants who've posed questions which we won't have time to answer here. However, we will forward these to Drs. Gore and Maud, and answers will be posted along with the webinar on the ASPHO website. Thank you so much to both of you for presenting today and for everybody on the line who's attending. Up on the screen is the next ASPHO webinar, so please consider attending November 17th at 2:30 Central Time, ASPHO's Compensation Survey Preview webinar. Thank you so much again, and I hope everybody has a great rest of your day. Bye-bye.